This is the title. I just need everyone to know that this presentation is not the science of SBIRT. It's more of the why, how, and what of SBIRT, how we experienced it as an FQHC, and how we went and evolved the process in our system, and then how that eventually evolved into a fairly integrative system at our particular site. So, okay, the next slide, please. Okay, that's just me. Okay, so I'm a big believer in doing things for the right reasons and the right way and so forth. And a big part of the way I do things is I have to be passionate about it. And SBIRT became very passionate for me for a number of reasons. Can you go to the next slide, Jessica?
Mm-hmm.
So this is my dad. A lot of us, especially I know a lot of social workers, a lot of counselors and so forth, and they all seem to have very personal stories as to why they got into the field. So this is my dad. He was a wonderful cook. He was a great chef, and the problem was he liked to eat as well. And over time, he became obese, and he ended up with diabetes. Well, as time went on, the diabetes became harder for him to manage. He still liked to eat, and back then, this is back in the 60s, 70s, every time my dad went to the doctor's office, the visit was usually about how much weight he lost and what his sugar level was, and that's it. Well, clearly, he was getting depressed, and over time, he got more and more depressed, and as his depression got worse, his management of his diabetes got worse, and the worse the diabetes got, the worse his depression got. So anyway, went back and forth for a while, and then it resulted in him committing suicide. Well, you know, as I grew older and went to medical school and started practicing medicine, I always wondered what the relationship between chronic diseases and behavioral health types of things are. And back when I went to medical school, there wasn't a whole lot of research or correlation behind that. And now we know that there's a high relevance between, especially chronic disease issues and behavioral health. So anyway, as time went on, I thought, well, as an FQHC, why aren't we more integrated? We've always had medical and dental as a kind of a integrated system, but we never brought in behavioral health. So anyway, a few years ago, I was turning the same age as my dad when he committed the suicide, and it was really bothering me. And as the days became closer, I kind of unrealistically panicked because you have very unreasonable thought processes. And one of the thought processes was, wow, am I going to commit suicide when I become his exact age? And, you know, they're very unreasonable and unrealistic, but some of you, I'm sure, can understand that process. And that's what was happening to me. But so I became very interested that there was a heightened sensitivity towards integration and SBIRT and so forth. I had read a few articles on SBIRT, and in my background, I'm a pediatrician by education training and so forth. So I'm not a psychiatrist and I'm not a behavioral health person. So, but I am the CEO of the organization, so I have the ability to direct the organization into various directions. So anyway, so I was very intrigued by the SBIRT notion, and I thought, well, why can't I do it on a mass scale in a large clinical setting like ours? So, so before I started, can we go next one, Jessica, please? I like quotes, so you know this has always been one of my mantras. Is why do a lot of us treat just medical? Why don't we treat the dental aspect? Why don't we treat the behavioral health aspect? And to me, that's true integration. You have to address health issues, to me, in a holistic way. And anyway, I've always liked this quote because it it pretty much epitomizes what I believe in terms of healthcare delivery. Okay, next. So anyway, so I ended up doing 4 clinical research things over like a 4-year period, and these are the 4 articles that I've written. The first 3 have been published. The 4th one is pending editorial review. But I wanted to see what exactly SBIRT was. How does it affect us in a clinical aspect? How does it integrate into everyday medical and dental procedures and processes? So that's the first article, and we're going to go over each one briefly, and then I'll open it up for questions and so forth. The second article came about, it's a survey article. I wanted to know what people thought. What did our medical patients think of us doing these questionnaires and screenings and so forth in a medical clinical setting? Most of the doctors and the nurse practitioners didn't, more the physicians, but they were very much against me doing this. And again, my benefit is that I'm the CEO, so I kind of, and I signed the checks. So that's supposed to be a little humor. And in a live audience, I get some feedback on laughing. But anyway, so I'm going to pretend that I'm hearing people laugh. But anyway, so I do have control over that, and I wanted to I did do the SBIRT, but I wanted to see what the patients felt about it. So it's a survey question. It's very interesting. I also surveyed the providers, and you'll see that in a few minutes. The third article was, what is the best way for a medical clinical program to integrate this whole behavioral health care model into the clinical setting? There weren't too many articles or too many resources when we were starting this to kind of give us an idea what is the best way of implementing these types of services. And then the fourth article, which I think is the best one, again, it's pending editorial review at this point, but I wanted to see what effects that this program had on our patients, what effects at all. And one of the big things that we were noticing was there was a significant reduction in the emergency room or emergency department visits. And we quantified some of that, and it's some pretty interesting results. So anyway, so those are the 4 articles that I'm going to talk about. They're not long. I know we only have an hour, so I'm not going to get into too details. So I'll superficially talk about it, and then I can get into more details as if there are any more specific questions. So, okay, the next slide, please, Jessica. Okay, we can go on. So this is the first article. Oh, I always put this slide up because, I run a lot. That's one of my hobbies. And usually if there are dogs out there, they'll bark at you and they'll chase you and so forth. But the cats always shy away. So the reason I put this up is because I encourage questions. And in a live audience, I encourage interruptions and so forth, because that's what makes the presentations better when there's much more interaction. So anyway, I know we can't do that, so I know I can't hear any barking and so forth. But again, that's another humor that I'm going to pretend you're laughing. So anyway, next, Jessica, please. Okay, so we know this. This is just to get us started. What is SBIRT? Screening, brief intervention, and referral to treatment. So, I'm not trying to insult your intelligence. I know we all know this, but it's a good way to kick this talk off. Okay, next. So I was telling you a little story about my dad, and during that time period, I was curious on what our FQHC rate, our organization's rate of diagnosis were in terms of certain behavioral health categories. So I was very interested in alcohol-related diagnosis, the alcoholism and so forth, the drugs, the substance abuse. We're talking other than the alcohol there, and I wanted to see the depression. So I went back and looked at our UDS. Some of you are FQHC folks, and you know what the UDS is. But For those of you who are not, UDS stands for Uniform Data System, and it's basically a report card that we send to the feds every year. Basically has demographic information, clinical information, and financial information. So anyway, we looked at some of these diagnoses. In 2011, if you look at the total, less than 1% had any of these three diagnoses. And in 2012, less than 2%. Now, in 2012, we reported the any level of diagnosis, whereas 2011 was what was, if any of these were primary diagnoses. So that's why there's a little bit of difference. But regardless, and where you see the N number, 54,000 in 2012, 48,000 in 2011. So less than 2% of the population that we served, or the patients we served, had any of these diagnoses. Well, that can't be right. And I'm in Northeast Ohio in the Youngstown area. It's part of the Rust Belt. The economy's poor and so forth. So, that's either telling us this data is either wrong or there's a lot of healthy people in this area, or maybe we're just not asking the questions. So, next slide. So this is kind of an old slide. It's probably updated. I've been using this for a number of years, but it's a Venn diagram. We know that at any given time period, people with mental disorders represent about a quarter of the population. People with medical conditions represent around 60%. So the overlapping is that 29% of the adults with medical conditions tend to have mental disorders, and 68% of adults with mental disorders have medical conditions. Again, the slide is a little old. I'm sure there's some updated things, but the point is we know that there's a lot of people walking out there who have behavioral health issues, mental disorders, and so forth. Okay, next, please. So we started, again, I told you the earlier story that I had a lot of resistance from my medical people. They didn't want to do it. So I talked them into, well, let's get some numbers and let's see what happens if we start screening our patients. So we started doing some real basic SBIRT screening, and we looked at alcohol, drugs, and depression. Those are the three main things we started out with. And you can see the numbers there. So from left to right, 3,125 patients kept appointments. Now, what we did was we looked at one clinic. We had a control as one of our sites, and then another site served as our test site. So anyway, at the test site, we had 3,125 kept appointments from February through August of 2013. And these were people who just had medical appointments and who were 18 and older. So we took away the kids and we just looked at the 18 and older folks. So once we took those out, we had about 2,500 patients that we actually did the SBIRT screening. So out of that, 793 had positive SBIRT indications. 542 had positive alcohol, and 235 had positive drugs. So for a total of 1,570, which is basically 2/3 of the patients that we saw. So right then and there, it tells you there's something wrong. So if 2/3 of the patients coming in and that we're screening are telling us that they have something going on, but our rate of diagnosis is less than 2%, well, something's not right. It doesn't match up real well. Okay, next one, Jessica. So we looked at the diagnostic rate. So after this research was done and we implemented SBIRT fully, and again, left to right. So YCHC was the test site. The WWCHC is the control site. So in 2012, our behavioral health diagnosis was 330 at this particular site. In 2013, during the SBIRT screening and the implementation of this, our rate of diagnosis, now these were people who told us that they have some depression issues and so forth, and then the medical provider actually made that diagnosis, committed it to the documentation. So it went from 330 to 627. So the rate of diagnosis increased by 90%. And then at the control site, it stayed relatively the same. So that immediately tells you that the screening process was pretty effective, because now we're identifying these people better, and we're actually making a diagnosis. Okay, next, please.
We've got a question. We've got a question that came in that pertains to the last slide.
Okay.
And it says, I'll pull up that slide right now. It says, does the total of 1,570 represent unique patients, or were some of those multiple diagnoses?
No, the number is obtained. Yes, they're not unique. They are, so some people could have two things going on.
Okay.
They could have depression and they could have an alcohol issue.
Okay.
So yes, so they're not totally unique.
Gotcha. All right, I'll advance to this slide.
Okay, so you already know that I like quotes, so I came up with this quote: "If you don't ask, they won't tell." And that's I think was what was happening in the past, is we as physicians are not trained very well in behavioral health. We never, I don't know these days, I think it's probably a little bit better, but back when I went to medical school and did my residency, behavioral health, mental health issues were all way in the back burner. You could take electives, but most people didn't. And that's a whole lecture in itself why this happens. But to put it succinctly, most of us tend to be more science-driven, more black and white, more database-driven. And I think behavioral health tends to be a little bit more gray, and it's not easily fixable. Doctors like to fix things. They give them drugs or they do surgery or whatever. To me, in mental health and behavioral health, that's sometimes I don't know if you ever really truly fix it. I don't know. And again, I'm not a behavioral health person. I'm a physician, so this is from my perspective. So I'm sure I'll get a lot of feedback on that. But anyway, as a physician and as an administrator of a large FQHC, I felt that this was a really important concept. Why aren't we doing these screenings all the time? And it was clear that once we did it, we were able to identify these the people who had some issues, and therefore we could do interventions. And isn't that our job as physicians, as medical practitioners? Isn't that part of our job, is to identify what's wrong with our patients? So anyway, so I thought this particular study was really good, and I did present it to my medical providers, and I did have some converts after that. Okay, next slide, please. Okay, so one of the gripes, and that's what I'll call it, one of the gripes by the physicians was that, this is just going to take us so much time. We won't be able to get our normal job done in terms of doing medical diagnosis and so forth. So anyway, part of the study, we did look at the time. So we looked at two particular physicians, Dr. S and Dr. K. So in the blue, this is in 2012, before we implemented any kind of SBIRT screening. So an average patient spent about an hour and 40 minutes in our clinical area. That's from checking at the front desk, going through the process, any labs, anything else that needed to be done, and then they exited. So roughly an hour and 40 minutes. Obviously, there's a lot of variables there. In 2013, when we implemented the SBIRT process, it went up to an hour and 45 minutes. But Dr. K actually went down. We never had any answers to that. And again, this isn't a real hardcore study, but it tells you that there's not really that much of an increase, if any, in terms of time commitment by doing SBIRTs here. So, okay, next slide. One of the problems we did run into was at that time we did not have an in-house behavioral health counseling program. We referred everything out to our community-based partners in terms of behavioral health. So what was happening was we got pretty good at identifying who has problems and who has issues and so forth. But when we made the referrals, they didn't go. And part of it had to do with timeliness. Sometimes it took 3 to 4 weeks to get them an appointment with a behavioral health counselor on the outside. So you can see this is a simple set of data, but starting on the left, YCHC, this is the test site. In 2012, 20.8% of the referrals of depression went. So out of all the depressed people that we referred, 20.8% went. 0% of the alcohol went for referrals and 0% of the drug people went. And in 2013, when we started the SBIRT, it did go up for the depression, but no one went for the alcohol and the drug counseling. And then you can see the two numbers for the control site. So okay, next slide. So that was a real problem for us, because what was happening was we got kind of good at being able to identify and diagnose some of these problems, but we had a really hard time with making referrals. And when we did, it was usually the time gap was pretty far out, and we felt that was probably why people didn't go to their counseling sessions. So that became a real problem, and it became kind of an ethical and a liability problem. So ethically, for me as a physician, I'm asking these people questions, do you have a problem with this? And they're telling me they do, but I can't get them into any counseling on a timely manner. And that was a real ethical issue for me. And then as the CEO of the organization, it became kind of a liability for me, because if I'm going out and doing these things, and if I'm asking them and I can't get them help right away, what happens if tomorrow they kill themselves? They trusted me. They told me that they have a severe depression problem or a severe drug problem, but I can't get them help right away. So that became kind of an issue, and I will talk about that a little bit later. But we did end up, long story short, we did end up creating our own internal behavioral health program, and thus the integration concept of this. But anyway, so the conclusions on this first set of research that we did, we felt that using the behavioral health screening tool in a medical setting certainly increases identification and therefore early intervention of behavioral health issues. So no doubt about it, this is a good thing. The science proves it. We also concluded that there's no negligible increase in provider time requirement. That's kind of just a myth. And then referring identified behavioral health patients to outside agencies did have its challenges, and it was a real problem for us. So, okay, next slide. So the next slide, my new set of slides, which we couldn't get up, had the Q&A period. So I'll stop here for a moment for any questions about this first set of research.
Okay, so a question I have here is, did you provide training on MI, motivational interviewing, so that your staff was prepared to do brief interventions? Yes,
that was all part of it. That's in the article, actually. I gave you the references for the article if you want to read it. But yes, they had extensive training. Actually, all the nurses did and all the providers did. Actually, it was you folks, Ireta. Do you say Ireta or Ireta?
Ireta.
Anyway, you folks came up and helped us out with that. Yeah. So yes, they did have training, and we had some other outside folks to help us with that. So yes, the answer is yes.
And also, in terms of the resistance from your medical staff, it sounds like time was one of the issues they were concerned about. Was there anything else that they repeatedly voiced as a concern?
Yes, and that's in the next research. But a major concern was they felt that this was too intrusive in a medical clinical setting, and they felt that the patients would not answer truthfully, and they felt that that it might create a distrust perspective. Now, these are all verbalized by the medical providers. And again, it kind of shows you that our training, at least physicians, I think the nurse practitioner training is much better than ours, but our training, didn't really support us too much in terms of how to understand this whole process. But those were the main ones, and I go into that in the next research presentation.
Okay, great. I think there's just one more question here.
Okay.
And it says, well, it's actually a couple questions in a row, but it's all from the same person. And it says,
Okay.
what was the mental health screening tool used? How was the screening administered? And was there any pre-screening done, like on a tablet in a waiting room?
Yes. So so that I will go over in the third research
Okay.
presentation, and I go into a little bit of detail there. Um, so yeah, I didn't go into that. It's in the article, but I didn't go into that in this presentation because I knew I was going to talk about it in the third part of this.
Okay, great. I think that's all the questions for now then. But you can
Okay.
feel free, the audience can chat them or put them in the Q&A box, and we'll make sure to pass them along.
Okay. So let's go back to the other one. So this is in Montana. It's called Lone Mountain, and there's an effect in the winter. This is called alpine gold because the mountain looks gold. This is not. I didn't fudge with the picture at all. So that's the way the mountain looked. Anyway, just a pretty picture. This is in the winter, obviously. So it's in Big Sky, Montana, if any of you been there or are there at this point. So, okay. Again, these pictures are an attempt to break any monotony that you may have experienced through my earlier talk. So again, I climb mountains as a hobby. This is Mount Shasta, and it just shows you, this is kind of a cool picture because it's showing in still life how difficult it is to climb some of these mountains. The slope is quite high or quite acute. So next one. Okay, so this is the survey research. So I called it SBIRT experiences. So we can go next slide. So again, this is a kind of a reminder side, and I titled this "People Want to Tell." So the results that I got shows very clearly that people are really good with us asking these questions. So out of that 3,125 appointments kept, and that goes back to those original numbers, the total eligible, again, we took out the people that were less than 18 years of age, 2,568 were eligible. 2,482 were okay with getting screened, and only 86 refused. So, and we gave them the choice to refuse. And, but again, you can see that overwhelmingly, people were okay with this process. Okay, next. So we had a lot of questions, and I just selected a few just for impact here, but they're all pretty similar in terms of answers. So the question was, prior to seeing the doctor, you were asked questions about your alcohol/drug use and mood today. Were you upset by having to complete these questions? So you can see the numbers. 91% said no, they were okay with it, and 9% said yeah, they were upset. So again, overwhelmingly, most people were okay with us doing this. Okay, next. If questions about drug/alcohol use and mood can help doctors improve care, would you recommend that others complete them? 99% said yeah, they were okay with that. So again, they were good with it. Okay. Now this is kind of interesting. Did you receive alcohol or drug counseling today? So this is after they've already said that they got a problem. So only 5% said that they got alcohol or drug counseling, and 95% said no, we didn't. Okay. So remember this slide. This is to kind of impact on the previous slide. So all those people, these people in this set, 63% said that, or there were 63% positives on this, but only 5% got what they felt was some kind of counseling or some kind of intervention or whatever from the doctor or anyone else. Okay. So we went and did the provider survey too. So we asked the providers, did you find the SBIRT process to be cumbersome? And remember, they already have a little bit of a negative attitude here. So 60% said, yeah, they found it cumbersome. 40% said no. How do you feel the SBIRT process changed the amount of time you spent with the patients? Well, 80% said they thought it increased the amount of time. But we already know from a previous time study that that really wasn't true. Okay, next. Do you think the patients were uncomfortable with the process? So 40% thought that they were. And remember, you go back to when we asked the patients, and they were overwhelmingly fine with it. And then, did you provide more intervention, discussion, or counseling because of the SBIRT? So 100%, all of them said, yeah, we did. But remember, 95% of the patients felt that they didn't. So clearly, there's a disconnect. One of the things that I do want to tell you, when we were asking the patients these questions, a lot of them said that they really didn't know that they could ask a doctor or a medical provider questions about or tell them about their behavioral health issues, which I thought was interesting. They viewed us as just like traditional medical types of things, sore throat, headaches, whatever. But if they were depressed, they really didn't talk about it. So I thought that was kind of an interesting anecdote to share with you. So, okay, next one. Okay, so and there's a lot more to the study, and again, I gave you the references at the beginning, but if you wanted to read it. But the conclusions were that patients obviously have no problems being asked behavioral health questions in the medical setting, unlike what the providers thought. The providers and patients have differing perspectives on the use of behavioral health screenings in the clinical setting. You can see there's a major mismatch on that. I don't really know exactly why. Does it have to do with maybe provider attitude or provider reluctance in doing this? I don't know, but clearly the most important partner here is the patients, and they're fine with it. And so I think this is, again, this proves that this whole SBIRT, the screening process, is a good process to do in a medical clinical setting. So I think the next slide, Jessica. Okay, so this was supposed to be a Q&A, and I purposely kept this one kind of short because there might be some more questions with it. So again, the take-home message on that particular research was people were okay with it. They were okay, they were fine with doing behavioral health screenings in a clinical setting, other than a counseling setting. It's a medical setting. So are there any questions on this?
We haven't gotten any questions submitted on this one.
Okay. All right.
Actually, I'm sorry. Now I can see a couple. Let's see. It says, how and where was the screening conducted? By whom and what was the tool used?
Yeah. Again, that's on the third one. That's on the next one in terms of how we did the process.
Okay.
So yeah, and I'll explain that in a minute.
Okay. And then I think this one is it's a lot like that. It has to do with the clinic flow.
Okay.
It says, what does SBIRT look like in a visit for you, both a negative and a positive screen?
Okay. All right. So so when I do the next set, that'll answer a lot of those questions.
Okay. And then I have another one here. Do you think physicians are uncomfortable asking questions about drug and alcohol use?
Yes, I do. And again, it goes back to it's something that we're not very well trained in. Again, you know, in medical school, there was for me there was a 8-week psych rotation, and there was 1 semester of psychiatry in terms of the classroom stuff. And that was it in residency. I'm a pediatrician, so I think we had a 4-week behavioral health rotation, and that was it. So yeah, we're not very good at it. We have a different mindset, so we, you know, a lot of us do avoid it. And then the other factor that's very common is, again, there's this notion and there's this perception that it takes a lot of time, and therefore they don't want to spend an extra amount of time seeing patients or listening to their, you know, their depression issues or their drug issues or whatever. And a lot of it has to do with reimbursement policies. Now that's changing. We're going from a volume-based to a value-based practice these days. So, you know, so I think it'll be better. But in the past, when reimbursement structures were tied into volume, you know, it was all about numbers, and you know, and so therefore, I do believe that the value-based type of reimbursement structures is much better. But anyway, that is an issue too. But yes, I do believe that the answer to that question is yes. I think a lot of physicians, not all, but I think a lot of physicians are uncomfortable with this. In my observation, I believe the nurse practitioners and the physician's assistants tend to be much more open to this idea than the physicians. From my observation, it's nothing scientific.
It's interesting. We have another question here. It says, so curious about the rate patients reported about counseling. So I think this is the low rate of patients who believe they had received counseling. And it says, do you think they actually received brief advice or brief interventions, but it was done with such a soft touch that they didn't view it as drug and alcohol counseling?
Yeah, I think so. Either that or, you know, again, especially the docs, I think they just really didn't know how to do it, you know, or maybe they just didn't do it. I don't know, because there was a lot of uncomfortableness. And until we started gathering the data and then doing regular presentations to the providers, again, they were very resistant. The attitude was poor, but they did, you know, again, most medical folks do like data, and they like to understand the data and so forth. So once we started presenting that to them, they became so-called believers. And but yeah, that was new at that time, and I think either they didn't know how to do it, or like the question was asked, was it done probably in a soft manner, and maybe the patients didn't really realize that it was an intervention. And the other thing is, could it be a definition problem? You know, maybe the provider thought, you know, maybe if I just say, oh, you know what, you're drinking too much, you need to cut back on it. You know, did they think that was an intervention? I guess it is a form of intervention, but the patient didn't view it as an intervention. So yeah, I think, again, you know, it's all about perception on that one. Again, that was a survey research, and it was about perceptions, and I thought the perceptions was interesting just to note.
This you may also be getting into in the third section. It says, was positive reinforcement offered and documented for all the patients who screened who were screened negative?
No, I don't think so.
Okay.
And again, you know, we were very very unsophisticated at the time. This was new to us. You know, remember, we didn't have on-site behavioral health counseling personnel at that point. So I'm sure there were a lot of things missed. My whole point on the first two research there was, should I be doing SBIRT screening to be able to identify these patients early on? And the second one was, do our patients have a problem with this? So it was a very broad study. It wasn't anything really highly specific or, you know, highly detailed. And again, at that time, we just didn't have the sophistication or the resources to be able to do a lot of things that we do these days, like the reinforcements and so forth.
Okay, great. I think that's all the questions we have for this section.
Okay. So this is Mount Hood. If it's in Oregon, it's one of the most beautiful mountains I've ever seen. It's a great climb if you haven't ever climbed there, if you like climbing mountains. But anyway, it's a very pretty mountain. So, okay, next. Mount Rainier. This is in Washington State. It's actually a difficult mountain to climb, and but it's a fun mountain to climb. So it's just very beautiful there too. Okay, next. Okay. In retrospect with these questions, I probably should have presented this one first, but this was actually third in my research, so I was going by more chronological order in terms of what I was doing at research. But the first two articles do talk about what the process was, but so that was the missing aspect, as it is clear now from all these questions. So anyway, so what is the best way to screen? So we knew from the first article that this was a good thing to do. We knew from the second article that people were okay with it. People actually liked it. So we wanted to know what is the best, and then with my business background, I wanted to look at efficiencies and effectiveness. So I kind of focused on that. What is the best way in a busy medical clinical setting to do SBIRT screening? So, okay, next. So that was kind of the premise behind this one. So when we first started, this is how we came up with a schematic, and starting from the left upper hand corner. So the patient presents to the clinical area. This was all paper at the beginning. So they were given SBIRT pre-screening questions. Can we go to the next slide real quick, Jessica? Okay, so we used this particular form, and it was just a 5-question questionnaire. It was basically yes and no. So this was we call this the pre-screening questionnaire. So we kind of focused in on the alcohol, the drugs, and the mood. And we wanted to, again, broadly figure out if anybody was having any of these problems. The mood is actually a PHQ-2. So two of the questions from the bigger PHQ is from there. Okay, so can we go back to the last one? So anyway, so that's what they got, and we did it in the waiting room. So they were given, they came into the front desk, they checked in, and then they were given this paper document that they had to fill out. And then once, and then they would give it back to the front desk person. The nurse would review it very quickly before they brought them in, and then if they were positive for anything, then the specific tests were given, the PHQ-9 or the audit for the alcohol or the DAS for the drugs. Again, please don't criticize it, because I can go back now, hindsight, and say, hey, yeah, that probably wasn't the best process, but that's the way we started it. And then that information was given to the provider. It was uploaded into the EMR, and then the provider reviewed it in the exam rooms. and then they went ahead and made the decision off the decision tree to your right. So that was the very basic process, and that's how we started at the very beginning. Okay, so next slide, and then the one after it. Okay, so again, this is just a written part of it. So we were looking, at that point, we were just looking for depression, alcohol, and drugs. And again, just to reiterate, we looked at patients only 18 and older, and we also made it a point to do it with every intake process. And the reason was we knew that roughly an average number of medical visits per patient was about 3 per year. And we wanted to make sure that we didn't miss anything. So what if they came in January but didn't come back until December? And we thought that was a lot of time there, and we wanted to make sure that with every visit that we would do it. Now, of course, there were some patients that came in every week. Well, that got a little monotonous for them and us. But that was our rules at the beginning. Our rules at the beginning also said that with every intake, if there was a positive, they would have to redo the whole PHQ-9 DAST or audit. Well, that went away very quickly because that became very prohibitive. So probably about 2-3 months into it, we decided that that they would only have to do it every 6 months if they were still positive. So so anyway, but that was again, please know that this is this is how we started. This isn't how we're doing it now. And then again, it was paper at the beginning, and then and this was one of my redo slides, but it was self-administered in the waiting room. If people had questions, we had the nurses help them answer if there were some literacy issues. So it was paper, and then we did evolve into electronic tablets, and that was supposed to be the second bullet point on the new slide. Okay, next, please. So then again, just to reiterate, after the pre-screening, anything positive, it kicked into the specific screening, and the reason was it was quantifiable, and most of them had some type of a legend where it says if you scored so and so, then the recommendation is to see a counselor immediately or whatever. So so we needed a quantifiable type of test. Okay, next. So this was a kind of a dumb slide. I just did it because I learned how to do it on one of these computer things. So, but it's more of an illustrative thing. I was just playing around here, so it's nothing. It doesn't mean, these pictures don't mean anything. That's Charlie the dog on the left, and that's Kitty the cat on the right lower picture. So, and then on the right upper, that's one of our dental clinics at one of our sites. So. Okay, next, please. So anyway, so after the screening, the data was reviewed by the provider, and then again, the provider had various options that they could do. So okay, next. Okay, so that was the original model, and that was during the test model there, that 6-month period where I wanted to see if this was effective or not. So so then I wanted to see, well, what is the most, we didn't feel that was very efficient and that was very effective. So we wanted to see what was the best model to administer SBIRT in a medical clinical setting. So again, I was looking at efficiencies and effectiveness. So we looked at 3 different processes. Okay, next. And that's what this research was about. So process A was using electronic tablets, but we wanted to use the electronic tablets also to gather other demographic information. And we thought, well, that was pretty clever because it's one of those we could kill 2 birds with 1 stone type of thing. So they fill out the electronic tablets for the behavioral health screening, and then they also update their demographic information and so forth. We had no behavioral health coordination at all with this. So it was just front desk to the patient, and then the patient to the nurses. Okay, so process B is the next slide. So the process B was, okay, do we just keep it at paper screening? So we looked at that model too. And then process C is the next one. So we felt, intuitively, we felt that this model was probably the best, and that's why we tested this. So let's use electronic tablets, but let's use it just for behavioral health screening. And then we'll hire a behavioral health coordinator who would help support the patient, would monitor who the positives were, and who made sure that they went for any kind of behavioral health counseling that was needed. So by this time, we had hired in-house counselors. So we started developing the behavioral health program with licensed counselors and so forth. And then plus we had ancillary support to support the process, and that's who we are calling behavioral health care coordinators. Okay, so next. Okay, so these were the brief findings. So I highlighted the important ones. So if you look at the top, it's A, B, and C. These are the processes, and then on the y-axis there, that's the different elements that we looked at. So if you look at the first yellow one on the right upper part under C, so we had a 99.5% of the folks were given SBIRTs. Okay, so if you look at the paper one and B, 94.6%, and then in A, 90.1%. There's a high refusal rate on A too. And we found that the reason was it got laborious for the patients. They were filling out this demographic stuff. They were filling out all these questions, answers to these questions. And plus now they had to do the behavioral health screening, and they didn't like it. It was too tedious, too time consuming. So that turned out to be a really bad model right at the beginning. So then the SBIRTs missed row, the fifth one down, is interesting too. And I don't really have an answer for this, but I think what happened was the front desk people just sometimes forgot to give them the paper forms to fill out. So I think it was more of a technical administrative aspect instead of a patient aspect. And then if you look at the column where it says positive SBIRTs, we found more positive SBIRTs with the tablets, with the other demographic data. I don't really have an answer to that either. I don't know why. But if you look, the variations aren't that much. But the last one, the brief interventions documented, was the most compelling. If they just did the SBIRT only with a care coordinator, the documentation was better, was the best. And with the paper and the other, it's pretty much the same. So that was, and then the p-value is very good on that one. So, okay, next, please. Okay, okay, so this is referral to behavioral health counseling characteristics continued. The most important one here is the total number of referrals that were made and kept, and that was the in-house ones, or I'm sorry, the total referrals, and that was the one with the tablet and the case management. So the take-home message here is the case manager, the behavioral health assistant type of person, that was the key in terms of having success in this particular model. And then the patients liked it where all they had to do was answer the SBIRT questions on the tablet instead of inputting all this other demographic data. So next one, please. Oh, okay, this was kind of interesting. So we looked at what the total time was on the process of the SBIRT, when we added the SBIRT type of things in this. And remember, this is a couple years later now. If you look, the times aren't that much different. The median time, this is in minutes, for the C the C model was 61.5 minutes. The A was the best, but we're not really sure why that was the best. So that really didn't do a whole lot for us. We kind of already knew that the C was the better model, so but we were interested in the time aspect too. But it really wasn't too much of a difference. Okay, next. Okay, so so again, the statement here is the combination of the electronic tablets, the EMR, and the care coordination was the best model in terms of successfully getting these SBIRTs done. So, and then this is just a synopsis of the big characteristics. So 99.5% of the patients completed their behavioral health screenings. The brief interventions were doubled with the other process, and then 100% of the referrals were made. So, so again, we as neophytes in this whole process wanted to know what the best model was in terms of doing SBIRT in a clinical medical setting, and that was our answer. So next one, I think that ends the segment. Yeah, okay, so questions and answers. And again, I'm purposely being superficial because I didn't want to go into a whole lot of detail. I didn't want to bore anybody or say things that that may not be for you.
Okie dokie. So one of the questions is, didn't you implement the models sequentially, model A, B, and C, with C being the last one introduced? And could it be that you got better rates and kind of a better effect with model C because everyone got better at doing SBIRT?
Absolutely. Yep. Yep. That is a very true statement. Yeah, that was, I think in my discussion, that was one of the thoughts or one of the points that I made. Yes. So absolutely, it could have been. But again, you know, intuitively and kind of common sense wise, it does make sense. If you have somebody kind of dogging the process with the patients, with the providers, with the referrals, that's really what made it. That was kind of the glue to bring everything together. And again, anecdotally, people did complain a lot about the model with the SBIRT as well as with the demographics. They just didn't want to do it. And when I did it myself, because I went and tried it, it was really, really prohibitive. So, yeah. And in the paper model, you know, again, the problem with the paper model was, you know, you can't get accurate data, you can't get good reports and those kinds of things. And it was, you know, too prohibitive. We have a very expensive EMR program, you know, and why not? So, but yes, that's a very true observation.
And this is an interesting question, I think. Do you have any advice for getting providers to agree to the SBIRT process?
Yeah, that's a really good question because as I've already confessed, you know, even though I'm a doc, I'm a colleague of theirs, they didn't want to do it. They really didn't want to do it. And again, I think it has to do with we're very uncomfortable with it. When we go to continuing education programs, we don't go to behavioral health ones because we don't really like it. And I'm talking about this collectively, and obviously not for every medical provider, but so my advice would be if you're non-physician type of person, as a physician, I can talk to them in the medical lingo. I can talk to them one-on-one. I think they have respect for me, and I have respect for them as physicians. So that helps on our end. And then plus, I invested a lot of time and effort in having meetings with them, you know, in small groups, and to talk about my data. But, you know, it's not always about the data. A lot of it has to do with the so-called touchy-feely things, the right brain stuff. So there were lots of anecdotal support for this as well. There were patients who came back. They might have been pink slipped, and they because they were in danger, and a couple months later they come back and tell that provider, you know, if you didn't, I was ready to kill myself that day, and you saved my life. I think those are very powerful things, and that's probably much more powerful than the analytical data. But that's how we did it, and now, you know, after what, 4 or 5 years now, it is, or longer, I guess. It is part of the practice. We initially implemented it as a quality improvement initiative, and because the data was compelling. So yeah, you know, you can't obviously make them become a believer, but I think these are ways to help, is to have, you know, to show the data, to prove it. That's why I did these research papers, because I wanted to prove that this was a good process. And then again, you know, from my right brain perspective, you know, I look back, and I told you the story about my dad at the beginning. I think maybe my dad didn't have to die that way. Maybe if the docs were more perceptive, and maybe if the docs were asked some of those questions, maybe he might have said that, yeah, I'm depressed, I don't, you know, feel right. Maybe an intervention could have been done then, whatever that may be, and maybe he didn't have to kill himself. You know, so I believe this is something very simple to do. It's very easy. It's very cost effective. Why not do it? We've already proved that it doesn't gain that much more in time. And since we implemented our behavioral health counselors, we integrated them into the clinical setting. Since we started doing that, you know, it's very little time from the docs. All the docs have to do is they see the SBIRT score, they see the specific scores, and they just push a button for a referral, an immediate referral, and, you know, and that's it. So it doesn't take them that much time. Most of the docs don't do their own interventions now, because we do have in-house counseling and so forth. So, you know, so that's a really long answer to that question, but it is a good question, because that is a difficulty of most medical facilities that I know of as well. They don't buy in. They're having a hard time having the medical folks buy into this. Yeah.
So I think you already touched on the answer to this person's first question, which is, who are the brief interventions done by? It sounds like mostly not the physicians.
Yeah, we want them to. They're allowed to do it, but again, sometimes they cite the time issue, and so yes, so either the nurse will do it, or nurses and so forth. Now we do have CDCAs, the chemical dependent counselors, and they will do it as well. So it depends on what the interventions are that's required.
Okay. The next question is, are you charging for SBIRT?
No.
Okay.
It's so we're an FQHC, so we get an inclusive, you know, pay rate type of thing, and so that's, you know, that's covered in that part, and predominantly our patients, and we do have some commercials, obviously, and yes, it goes on there, but typically they're not paid. There might be 1 or 2 commercials that will pay for that process, but I think most of them don't. But we just basically write that off.
And here, this is the last question that I see right now, and it's about a screening tool called the CUDIT, which I believe is Cannabis Use Disorder Identification Test. Okay. And the person asks, should they be utilizing that, given that the DAST already covers cannabis? Is it necessary to use the CUDIT?
You know, in all my readings about this whole SBIRT process, you know, it's up to the individual groups or organizations, I think. So I think if that's a huge problem in your area, if it was me, I'd probably consider going into a little bit more detail if that seems to be more of an issue there. Like here, we don't think it is. We don't know absolutely, but we just cover it through the DAST, and you know, so I think it's one of those individualized things, programs that you create. You know, again, you saw initially we looked at, for our pre-screening, we're basically looking at just alcohol, drugs as a whole, and mood. But we've since expanded that. We're looking at things like anxiety. We're doing all kinds of screening with the kids as well. So, you know, so I don't really have a particular answer to that. I think it depends on your area and what your demographics are showing in terms of you know, the problems and issues there.
This question is, how are you satisfying the UDS requirement to document SBIRT since a 15-minute insurance minimum provider face-to-face is required with the patient?
Well, I'm not really sure if I understand that. How are we documenting the SBIRT encounter?
Let's see. Yeah, it says, how are you satisfying the UDS requirement with documenting SBIRT? Yeah, I don't know if there's more detail that person can offer.
You know, I can, is there a way of looking at that question and I can get back to them? Because I would have to ask our, all of our analytic folks that deal with that. Because I don't think I could probably answer that because I don't do the UDS, you know, amount. I don't compile the data. So we can ask our analytics data person and then we can answer that later if that's okay.
Okay, terrific. Yeah, I think that is all of the questions that have been submitted so far.
Okay. I'm running out of, or did I run out of time already?
No, we have till 3:30.
Okay, all right. So this is the last section. Okay, so getting back to the photos. So up on the mountains, high up, there are a lot of what they call crevasses. Lower down, they would be called crevices, but these are crevasses. And they're basically deep fissures within the ice. And sometimes they're very long, up to a mile, a couple miles long. And if you fall in it, you basically die. Unless you fall on a ledge or something. And so it is very treacherous up there, and we frequently use aluminum ladders to get across. And that's just a photo. That's that one's at Mount Rainier. So okay, next please. This is Mount Rainier going down. It's kind of a cool picture because it was done on one of those GoPros. Okay. Okay, so this is the last one. This one hasn't been published yet, but again, I was curious to see, well, what impact has it had on the organization as a whole, or even in economics perspective. So I didn't really go deeply into the economics things, but there's a lot of inferences that can be made. So, okay, next slide, please. So, and this was a pretty simple data set that we reviewed. We got some data on emergency room utilization from one of our Medicaid managed care organizations in Ohio. And the N number on this particular slide is 12,440. So there were 12,440 patients that were looked at during this time period of 2013 through beginning of 2016. So so this particular slide looks at the average number of emergency room visits, and we divided this up. So the top row, or the top graph, is our known patients with behavioral health problems within the organization that went to the emergency room for either they ended up with a behavioral health diagnosis or a medical diagnosis. So we wanted to see what their utilization rates were. Then the blue one is that they went to the ER just for behavioral health visits. And then the gray one is just for visits for non-behavioral health. These are non-behavioral health patients, so they never had any behavioral health diagnosis, and they just went to the ER. So, so you can see the numbers. People who have behavioral health issues go to the ER a little bit more frequently than the other folks. But if you look kind of halfway, you see that the graph goes down. And that was the intervention period. That's what, quarter for around 2014. So that's when we added the behavioral health people, and we embedded them into the clinical area. And you can see that that the ER visit starts declining right in that period, quarter three, maybe, I guess 2014. So it starts declining, and that was significant. So if we go to the next slide, I think that gives us the numbers. Okay, so this is a little bit of a tricky one to read unless you're a statistician, but if you look at the top left number, 2.876, so that was the average number of visits. But if you look at the third line at the intervention site, the intervention period, it dropped by 1.108 patient. These are averages per quarter. So you can see there's a drastic drop once we implemented the behavioral health program, where we added counselors and the behavioral health assistants and so forth into the clinical area. Okay, next one. And this one is for the only the behavioral health visit ones. So you can see there's not that much of a change in this one, only a 0.004 change in the average. Okay, and then the next one are just the medical visits with non-behavioral health patients, and you can see there's negligible change there. So if we could go back to the first one of this series. So again, you can see that that there's a significant decline once we implemented the behavioral health counseling. We integrated it into our clinical area. So that, you know, proves that that this was effective. And there's a lot of reasons for it, I think. One is that okay, once we get the counseling involved on a regular basis, did that give our patients a little bit more of a comfort blanket, so to speak? They're able to talk about their problems. Are they taking better care of themselves now? You know, they have a person that they can identify with. There's probably a lot of reasons, and you folks out there, most of you are behavioral health people, you probably have better ideas on why this is happening. But we do know, again, I as an administrator and as a physician know that, again, it goes back to bringing in behavioral health counseling into the medical setting, doing these screenings, and I can see that it helps significantly to decrease the emergency room visits. Well, you know, and that obviously has economic impact. Well, if they're using the emergency room less, then that's, you know, better for the economy as well. So, okay, so we can go back and jump ahead 2 more slides, and let's see. Okay, so the conclusion for this study was integrating on-site behavioral health services as part of a healthcare delivery program results in a decline in the ED utilization by behavioral health patients. So that's proven statistically, and you know, and intuitively, of course, we would think that, but it is proved scientifically that, yeah, it's really a good thing. So again, the whole thing here is it worth screening for behavioral health issues in a large medical organization? So the answer is yes. We proved this. The patients like it. They're very fine with it. You know, now they're being able to tell us that they got problems. The third one is, you know, again, the third one is more technical. What was the best way of doing this? And then the fourth one proves that these people are better able to take care of themselves. They're probably a little bit healthier once we integrate it. So again, the big picture is very simple. But again, I wanted to share all these different research that we did because these are all quantifiable and these are hardcore, solid stuff that a lot of doctors like to look at. So, so I think that's it, Jessica. The rest of his pictures.
Shall I advance them so people can see the pictures?
Yes, please. Oh, okay. So this is Mount Washington in New Hampshire. That was one, even though it was only 6,000 feet high, it was one of the hardest climbs. It was a total whiteout there, and behind the sign, probably about 20 yards behind, is actually a building. It's a weather building back there, but we had a total whiteout, and you can see we're totally covered there. So that was a pretty rough climb. Next. Oh, this is climbing up Mount Rainier. It's just kind of puts things in perspective. Okay, next. Okay, we talked about this already. I ended up talking about it earlier, but this was the ethical and liability considerations that we all need to be aware of when we do this kind of stuff. So, okay, next. Oh, this is Mount Fuji in Japan. I climbed that too, and this was a route I took. It's kind of more of a wilderness route, and it's a beautiful mountain. One of those perfect cones up at the top. When you look down, it's a volcano mountain as well. And then the next one, Kilimanjaro. I climbed that last year. That was an incredible climb. It's like 19,000 feet high, very, very tall mountain. It took us 2 weeks to climb it, but and I had more Kilimanjaro pictures on my youth set of slides, but anyway, I think that's the last slide here. So yeah, so that concludes the talk. Again, I apologize if this was a little bit awkward because I feel awkward talking to the computer, but anyway, again, I'm a big picture guy because I am the CEO of this organization. But the big picture again is this is a good process, and why aren't we all integrating our services? And we know that there's relevance. There's a lot of comorbid conditions that occur. We know that just because you have a sore throat doesn't mean that you don't have a depression issue or a drug problem or anything. You know, so I think we got a long ways to go as healthcare organizations do, and a lot of the one of the good news things that I've observed is a lot of the younger doctors coming out of residency in medical school and so forth. It seems like they're having more of these types of issues being known to them. They understand social determinants of health. They're, you know, so and these were foreign words to us back when we were in school. So that's the good news. Is I think people are going to jump on the bandwagon, but I think you know, we need to do more of these types of talks to the doctors. I think at the beginning when Jessica did the survey, I don't think there were any physicians on this call. And that tells you right away that, you know, I don't know, there's either lack of interest or they just don't believe it or whatever. So, and I'm not trying to knock doctors because I am one, but that's just what I think. I'm rambling out.
Well, we don't have, well, we've got a lot of little messages saying thank you so much, and that people thought this was a great presentation, and the pictures are beautiful.
Oh, good. I didn't have any mountain questions.
I have another question that's connected to the UDS insurance reimbursement question, and I will send that to you over emails, and we'll be able to get the answer out to everybody on the all the participants. So even folks that are less interested in that answer will also get to hear your answer on that.
Okay.
And yes, I want to thank you on behalf of IRETA because I know that webinars are not always you don't get a lot of feedback from your audience, but it's a great way to reach people kind of all over the country while they're in their offices. So we really appreciate you leading this webinar.
Okay.
And now I have just a little bit of housekeeping to explain to people how they can get CEUs.
Okay.
So let's see if I can pull up my other PowerPoint. So basically, here we go. So thanks, of course, to Dr. Dwinnells for presenting the webinar, but thanks also to all of you who participated. It was great to hear from you over chat. In terms of the evaluation and CEUs, we're going to send you a couple of emails following this webinar. In these emails, there will be a link to the recording of the webinar, so you can watch this again, and we'll give you a copy of the slides from today. We will also send you a link to the evaluation. We would really love it if you would fill out the evaluation. It should take no more than 2 minutes of your time, and it helps us do better presentations for you in the future. Following the evaluation is a request form for a certificate of attendance or NADAC PCB CEUs. If you don't want to fill out the evaluation and proceed directly to the CEU request, you can just leave all of the answers blank on the evaluation, and you'll be able to request CEUs. And then here you see, if you log into My IRETA, you'll be able to click on the webinar that you attended. And at the bottom of the page, you'll see options for CEUs, NADAC, PCB, and a certificate of attendance. You can download the certificate, and you'll get a PDF of your certificate. And of course, we would love it if you would continue to register for upcoming IRETA webinars. It's on our website. We have a couple more. We have an October webinar on the Communities That Care prevention model, and a December webinar that might be of interest for you folks. It's called How Harm Reduction Fits into the SBIRT Model. And of course, if you have any questions about CEUs or anything you saw in the webinar, please get in touch with us. You can email us at info@ireta.org. So with that, I'll conclude the webinar. Thank you, Dr. Dwinnells, and thanks to everyone for participating.
Well, thank you. And you'll send me those questions, and then I'll send them back to you.
I certainly will.
Okay, great. Thanks.
All right. Thank you.
Okay. Bye.
Bye-bye.